Good afternoon, everyone. It's funny. I'm used to being on Teams and then you can see all the little faces joining, but I've just realized you are joining because the numbers are clocking up. So we'll start straight away in the interest of time. Good afternoon and welcome. Thank you very much for coming. I'm Elizabeth Taylor and I'll be facilitating today's session with my colleague Susie Salamoni. And that's part of our roles at RCOT in developing a culture in the profession where everyone feels confident in using data and evidence to demonstrate the value of what we do as occupational therapists. So I'm sure that number will carry on clocking up and people will be joining us online over the next few minutes. We've actually got a bit of a technical glitch with one of our panelists, so hopefully that will be resolving in the background as well. But thank you for being here for this really important discussion on evidencing the impact of occupational therapy. This session's part of an ongoing conversation that we're having as a profession, and it's backed up by a package of practical support and resources that RCOT is developing to help you evidence your impact in real, meaningful ways. It's about building confidence, whether you're working in health, social care, education, research, or elsewhere. We want you to have the confidence in choosing the right outcome measures, embedding their use into everyday practice, and using the right data to drive recognition and improvement. So this afternoon, we will be exploring three key questions with our expert panelists. Those are, why is it important to collect and share evidence of our impact? How can we choose the right evidence and make it part of everyday practice? And what kinds of evidence best show the value of occupational therapy? But before we start that conversation, I want to let you know that this is the first of two panel discussions, maybe more if there's an appetite for more. We'll be running a follow-up session on Monday, the 17th of November, and that will focus specifically on leading to demonstrate impact. So that one's for those of you in leadership roles, perhaps senior leadership roles across services, and it's going to focus more on how you use your data strategically with decision makers and stakeholders. We will pop the link in the chat for that, so you can register for that event too. So what we really want is for you to leave today with practical ideas, renewed motivation, and a sense of collective purpose. So in a moment, I'll hand over to our panelists who bring a wealth of experience and insight to this conversation, and they will introduce themselves and share what drives their passion for this topic. And then after that, Susie will facilitate our discussion around those questions. We are recording. Please do engage as we go. Use the chat. If you're not used to Zoom, take a second just to remember where everything is. So you can use the reactions function, show all your love. You can post any questions into the Q&A space. And if your question is for a specific panelist, if you could just pop their name at the start, then it'll be easier for me to field those questions and direct it easily. So we want this to be a session that inspires practical action. So as we go along, just keep in mind, what are your take-home thoughts from this? What will your next steps be? And we will send you the recording and an evaluation form afterwards, and we'll be asking you those questions on the form. So you might also want to jot ideas down as we go. And remember that this is all part of your CPD as well. Anything else to say? We'll send you the recording. The recording will also be available on our assessment and outcome measures webpage. So we will put the link in the chat for that as well. So let's get started. Shall we start with an introduction from you, Alex, and then you can pass the baton to Catherine, and Catherine can pass the baton to Joe. And I can see some of you are introducing yourselves in the chat, which is great. Please do carry on doing that. So over to Alex.
No problem. Thanks very much. Good afternoon. I'm Alex Gick. I'm an AHP strategic lead for community and intermediate care in Cardiff and Vale University Health Board, but I am OT by background, having only recently gone into this post in May. So just a little bit of background about me. You'll see me glancing off because I've got some crib sheets, otherwise I'll just waffle on for a while. So I qualified from Cardiff University in 2005. I think I was just someone that really wanted to embrace as many opportunities and areas of practice as possible. But I did find those experiences only really happened within that adult arena. I never experienced anything in peds. But ultimately, I think I knew very early on within that the place for me really was community. And that's where I really wanted to have that development of my skills and knowledge and a passion to be within that area. So where did my passion around the topic of outcomes develop? I think as like many other junior staff, my outlook was I do it because that's what I'm told to do. But I never really knew what happened with it afterwards. No one ever really took the time to explain this is why we do it, this is where it goes, this is how it's used. So in 2010, I actually took a career break and I moved to Vancouver for 9 months. In honesty, I was probably questioning quite a lot within my career at that point in time. I'd been practicing for 5 years by that point. And I think I was unsure whether I was going to returns. But anyway, whilst there, I started working in hospitality and I worked in a five-star hotel and I was actually cleaning rooms. But really interestingly, the ethos within hospitality and particularly within this hotel was you do everything possible to make the guest experience as great and as faultless as it can possibly be. So everything is just about the minute and the fine details within that. And it might sound a daft thing to say, but I got promoted quite quickly, and that led me into managing the mini bar stock. And it's quite funny because when we were doing the pre-session meetings around this, Susie had mentioned this to me because I think Genevieve had mentioned it from a previous presentation, and I had no idea my reputation for working with mini bars had spread more broadly than what it was when I did the career break. But doing that, it was really interesting because then I understood what pressure was or the impact that I could have upon experience because you don't want to leave people without their snacks and alcohol on business trips or holidays, to be honest. And whilst that can sound like a bit of a joke, it really resonated with me about what experiences mean for people and how simple things can either enhance or take away from those experiences. And as cheesy as it might sound, it was one of the things that relit the spark for me, really, and led me to wanting to come back. So I cut short the planned year out, returned to work. I wrote an article for OT News about that experience, signed up for a master's in advanced and healthcare practice, and then started to apply myself in a different way. I I think I came back with that renewed enthusiasm, realizing that my banding didn't matter. What I was mattered more, and I could lead from wherever I was. So ever since, I guess it's been a bit of a journey for me in terms of learning and applying that into practice. With a lot of work, I'm really proud to have been a part of, particularly around the developments of OTs working with in primary care in Wales. The last four roles that I've done have all been new emerging roles. So I think that probably shows in a nutshell that I've got quite a passion for developing services, demonstrating value in it, and that I really do quite enjoy being outside of my own comfort zone. So now that I'm in that AHP strategic leadership role, I think part of the biggest draw for me within that was that ability to reach into even wider forums and to influence even more. So the last thing that I'll say from the introduction is simply put, I don't class myself as an expert on outcomes. So I don't want to disappoint anyone in terms of the expectations around that, because we've got an amazingly skilled world of OTs in the UK and lots of experience that we can draw from. But what I hope to put forward, I guess, is my passion about enabling and showing others what they can do, the value of doing it, and how to use outcomes in that really multifaceted way to tell a story that really needs to be told. And that's it from me. So I'm going to pass on to Catherine.
Thanks very much, Alex. And so I'm an occupational therapist by training as well. I'm from Canada here. I'm an associate professor at the School of Rehabilitation Therapy at Queen's University in Kingston, Ontario. So Ontario is one of the largest provinces and most populated provinces in Canada with 5 occupational therapy programs. I'm also the director of the Health Services and Policy Research Institute here at our university. And so I have had a long-standing career-long interest in outcome measures. I graduated in 1995 and immediately jumped into a position, and outcomes became something I was intrigued with from the start. Really, I think trying to figure out what I was doing and trying to see if what I was doing actually mattered. And, from there, it really just snowballed. I went back and did my master's in 1997 at University of British Columbia, Alex, Vancouver, lived there for 10 years. And my master's actually looked at individualized outcome measures, which now we know as as PROMs. We call them patient-reported outcome measures. We think of them as goal-oriented care, but really thinking about, how can what matters to them, can we measure that over time, and can we see that we make a difference to what matters to people? I've since gone back to do my PhD. I did my PhD in evaluation, so I'm highly committed to outcomes and measurement, and really have over time taken my interest to health systems more broadly. So, at first thinking about, I'm going to say assessment. So thinking about, when I did an assessment, did I choose the right assessment to make decisions about point of care? Then I became interested in outcomes. Did what I do make a difference over time? So my assessments were done on an individual initial assessment, make some individual plans. Then I wanted to think about, can I make a difference over time? And I think about outcomes, where you submit an assessment over time to see if there's change. Now I've been much more interested in performance measurement. So looking at like a broader health system and how we actually use that data to make big decisions around resource allocation. And I've really think to myself, occupational therapists can use outcomes to be seen in the system. And thinking about, how do they leverage the data they collect to show impact on a broader scale, and think about populations and what kind of populations they're able to make an impact on. So again, going from sort of this individual understanding of how I choose the right assessment tool to moving to outcomes in terms of programmatic evaluation to think about broader systems. And I'm happy to talk a bit more about how we make decisions around all that. But, I can see what you measure, like you have to measure what counts, and what counts gets measured. So I think making these clear decisions as occupational therapists make a big difference. And I'm going to pass it over to Joanne.
Thank you so much. So I've got a few slides just to keep me on track. So I think Kinza is like kindly sharing that for me. So my name is Jo Ellis-Staggs. I work within South West London and St George's Mental Health NHS Trust, and I've worked in mental health for about 10 years now. I work within 2 roles, so I've been very fortunate to kind of forge a career, so between OT practice development, and I'm also the Chief Professional Information Officer, or CPIO for acronyms, for allied health professionals and community nursing. So that is a digital role for clinicians, so I'm kind of spanning the digital and clinical sphere. And I'm leading and supporting in many, many projects, I'm sure we all are, across our trust, including improving digital skills for our staff, patient engagement portal, improving allied health professional onboarding, so very workforce-based task, and how we digitally configure ourselves, and many, many more. But to focus on outcome measures, if we go on to the next slide, in terms of my experience, I transitioned to from frontline OT into OT leadership, so I was able to see the situation regarding use of outcome measures and that data from both angles, from being a clinician on the ground to actually being in meetings where we're having to present our value. I'm very passionate in problem solving, sometimes to my detriment. I really am keen on making things more lean, and also about working smarter, not harder. And I've observed the need for evidence, which is growing all the time in different meetings. I've absorbed and been part of lots of different kind of circles and meetings and opportunities, hearing the need for evidence. So that really kind of fueled my passion into outcome measures. I ask a lot of questions, and I like to see things with many angles as possible. So sometimes I can seem a bit of a fence sitter because I'm trying to see it from lots of different points of views, but I feel that's really, really helpful when you're thinking about solutions or what we can do going forward. I've attended some training where I'm able to access our internal kind of data warehouse. So I was very much exploring that about data. What can we use? So what can we get from OT outcome measures, and what other measures could we use? And by doing that, I built very strong relationships, or annoyed people a lot, in terms of with data analysts, our information management team, and digital teams, which kind of led to my digital career. My first project was looking at how we track the OT process using data, so including outcome measures, but it's led to many more, so I just wanted to give a bit of an overview in the next slide. So as you can see, a lot. So in terms of outcome measures, that is through and through all of this, because we needed to think about how we actually screen people to actually consider if we are seeing them within OT, and then we're looking at what the problems about data collection. Why are we struggling to get those outcome measures? Then thinking about, do we need to create any more solutions for like services where we might not be able to capture certain data on our electronic patient record system? And then improving how OTs actually demonstrate what they are doing in appointments, because that is a useful measure to go alongside our OT outcome measures. So lots of there about building reports and working with other services, and also looking at assessment data, actually looking at that data to pull and kind of reviewing what trends are we seeing. We use MoHo, so we look at MoHos quite a lot. Where are we seeing improvement? Where, in what particular domains is that expected in acute versus community? Kind of analysing that a lot through Excel. Very much self-taught doing that. And then also looking at other outcomes. For example, is there a theory that if someone sees an OT, are they less likely to be re-referred to a community mental health team, as an example? So my work has spanned a lot of trial and error over a lot of time, and I'm just really passionate on improvement and making things better. So there is an element of actually being able to access data, also supporting our staff to understand the value of collecting that, because often we are so caught up in making things better for people, we don't always capture that data. So a lot of my work, which I'll go into later with the questions, is about how we help staff and how we change culture around data rather than seeing it as a very much separate entity. Yeah, so that's me.
Thank you so much, Jo. So we're super blessed to have the three of you today to be our panel members. I thought what I might do is just maybe start, so running a little ahead of agenda, which is always a great feeling. How long will that last? Is I thought maybe I'd just introduce myself too. So obviously Elizabeth and I work together, and I'm the Service Innovation Manager, RCOT. And the reason why I guess I thought it'd be worth just sharing that is one of the things, or the main job that I do at RCOT is I lead improvement. And as of April this year, I've begun to build sort of the first ever UK improvement database of occupational therapy-led change projects. And that's been really interesting for me from an outcome measures perspective. And just to speak to that a little bit, over the last couple of years, we've had 200 improvement projects come in, of which only 36 have made it onto our database because they have outcome measure data to prove that the change made a difference and improved practice. And so that's where my passion really lies, in this whole area really. And so yeah, hence I'm here hosting this this sort of panel discussion. So let's kickstart then the first question. So what I want to say, just for the audience out there, how did we choose these two questions? So I asked all of our panel members today, what are the most common questions that you get asked as people that are leading this sort of outcome agenda, perhaps in their workplace, what you get? And all three unanimously said the same two questions. So we're going to go with those, and they were no surprise to me and Elizabeth either. So we're going to have about sort of answers to questions for about 20 minutes. So question one will be about 10 minutes, and all panelists will get the opportunity to answer it. So I'm going to head over to Alex first for the first question. And that is, why capture outcomes data as occupational therapists?
You know, where to start? I think the easiest place to start is because we have to demonstrate what we're doing. But what I want people to really get on board with is that desire to demonstrate our value and continue to raise that profile of the amazing contribution OT is making within health, social care delivery, as well as other areas like private practice. So I think for me, that why is often caught up in what are we delivering, which is part of the next question, I know. But what are we trying to demonstrate? What are we trying to prove? And who are we trying to prove it to? So obviously there's normally a wide range of stakeholders that are involved, from our patients all the way through to execs, for instance. So why we're capturing data is often quite wide in terms of the approach that we have to take, because in one form we might need to demonstrate why we're doing it, what are the patient values, what do they want from it, what do those patient groups, co-production, all of that want to see from it. In another section, you might have your OT management that wants a certain element from it, but then we got to think about the bigger system as well. So I think sometimes we've got to take a step back and look at ourselves within the broader system. I think Catherine was already talking about that in her intro there, that we contribute to a wider system and a wider model, but we've got to be loud and proud at doing that. So we've got to put our heads above the parapet. We've got to be willing to kind of step forward and say, this is what we're doing, but without the context behind it, going, this is why we're doing it. This is where we're going to start falling down. If we can't put business cases together to show what the value of occupational therapy is within a setting, then it's very difficult for us to get involved within those conversations, to show that value, to show that worth, to even be able to contribute to what those outcomes might potentially be if we are part of those teams and those discussions as well. So I always think about kind of why capture outcomes is often we've got us that very first word, why, is often the thing that we need to keep drilling down into all of the time. If we've got a service, like let's say a full service, and we're capturing data within that, then why are we capturing data? What do we want to prove? What do we want to demonstrate? So it could be, oh, we want to reduce falls. Ask the question again, why? And you've almost got to keep going with that why question until you get to that point where you can't ask the why question anymore. So if you really think about what are we doing to reduce falls, then actually the broader context of that means we want people to be able to live as independently as possible at home for as long as possible at their normal place of residence without the impact of what falls might have. So for an individual, that might be not having to have a care package. That might mean just being able to cope generally at home, or to be able to have the support from their family members to exist at home continue. But unless we really drill down into the why, then it's very difficult for us to identify the what, is probably my main point around that. But I just, going back to what Catherine said, I do think the context of putting ourselves within the wider system is absolutely key to the why capture the outcomes. Don't do it in isolation as OTs, do it as part of the bigger system and contribute into that.
Thank you so much, Alex. I realise I'm going to find this job of timekeeping and interviewing you all quite difficult because I've got so much to say already and we've only had the first first answer. But I thought maybe what I might do, try and keep it brief, is just sort of, I think there were three things that spoke to me there, but I'm going to talk about two of them. I think if I was an occupational therapist starting out again in practice, where everything feels quite new, I think you're spot on there in terms of talking about who the audience is. And I think I would be wanting to know where this data is going, who's interested in it. And I think that's one thing I'd be doing if I was an early career occupational therapist, to sort of understand that. And then I think the other thing I thought about as well as being an early career occupational therapist is that you're passionate at that point. You know, you're armed with your new knowledge, you're excited about joining the profession as occupational therapist. And I think it doesn't sort of take long, I suppose, before you start to think, oh, it's quite busy around here in this context. There's a lot of people proving their worth. So I think capitalizing on that passion as well and using outcome measures to be able to demonstrate is another great a thing to be focusing on. And you also, of course, dropped in a sort of an improvement tool as well to kind of start that conversation in your teams, which is the 5 Whys tool as well. So an excellent suggestion. Over to Catherine for the same question. So why capture outcomes data as occupational therapists?
You know what, Alex took the words out of my mouth, so I'm going to say ditto. So I'm going to take it on a bit of a different angle because I've also done everything he's talked about in terms of thinking of the, who the data is for is crucial. And, but what I'm going to use is an example from primary care. And I'm going to throw 2 articles in the chat too, because Laura Ingham has just published 2 amazing articles for people who are interested in outcome measures. I love how she's done this work in primary care and thinking about how you can use outcomes to coalesce and describe our own values. And so her articles are about looking at evaluating occupational therapists in primary care using a value-based outcome lens. And so I really love how she's thinking about outcomes to align our occupational therapy values with the values of the broader system, and actually using outcomes to help us understand what we ourselves are doing in a new area, in a new practice setting. So I've been working in primary care, and that's my big passion and focus. And when we think about outcomes, and so we actually used outcomes 20 years ago when we came together and got our first funding for looking at occupational therapists in primary care and in GP's offices. And the first thing we did, we came together and we sort of grew as one therapist working in primary care and then another. And the first thing we did was we have to figure out what we're doing. And we have to figure out what we're doing by coming together around a common outcome measure so we can actually have some common language across practices, because no one was telling us what to do. I should backtrack a little bit too. So I actually have, until COVID, always had a clinical practice as well as an academic practice. So I worked in a family physician's office as a primary care occupational therapist. So I both lived the experience of trying to figure out how we use outcomes in primary care in a brand new setting. So it was a way to bring people together. So I don't think we talk about outcomes like that as much. So we came together, we worked to decide what outcome measure we wanted to use, and we actually used that data, not just at that point to describe our value, which we needed to, but to describe actually what our practice was. So I'm going to say outcomes can help us describe and understand what we do in new settings and help to use that data to further expand our roles into settings that most align with our values.
Thank you so much, Catherine, and for also highlighting Laura's work. Unless there is two Laura Inghams, I believe Laura Ingham is actually on the call today. So maybe she can pop in the chat for everybody a link to her fabulous work. So over to you, Jo. What is your answer to why capture outcomes as occupational therapists?
I think ditto times two as well. So I think I'll kind of add anything extra. But I just, the only point I want to expand on is why. I think why is always really important, because I think that there are plenty of examples I can think where data has been collected and then just left. It's like, well, that's what we do. We collect this, and it's, well, what do we do with that? Do we need to collect it? That's another task. Is that lean? So I think why is always good, and to think about really down to the detail. Why are we doing this? So just to kind of reiterate that. But I think from a client point of view, there's a kind of a 3 C's in terms of checking, capturing, and actually communicating that progress. So that I think at the client level, I think that's really positive. You know, I can think of examples where OTs have come to me and said, oh, I had a conversation with my client and showed them their assessment pre and post, and they were really like pleased. They didn't realize how much progress they'd made. And actually that was a really nice conversation, because I think sometimes, particularly in mental health, things are complicated, and you know, people might have lots of problems, but actually we can get engulfed. We've got one thing going on, we can get engulfed by that, but actually not see the improvements we made in other places. So I think that's a really nice way to be able to demonstrate and communicate those positive, you know, not always positive, but hopefully positive changes. Also, the need in the NHS is we need more. The need for data and evidence is just growing all of the time, and I think OT is possibly less understood than other professions. And I think in mental health, where I'm obviously working, there is a sometimes feels a little bit more grey. We are doing some elements of generic working, and I think that as much as it's really positive that we're holistic, it can also be a negative, and actually being able to demonstrate what we can do. And I think Alex, again, loud and proud comment kind of struck me, because I sometimes doesn't feel that we are loud enough or proud enough, because we're always thinking about other people's contributions to the MDT, which is important, but we also provide a really big service within our MDTs. So I think it is really useful to have that outcome data to also help people understand our role, because I think that is obviously very difficult. And part of that is future-proofing our workforce, because ultimately when we are frontline clinicians and we're working in services, or we're even supervising frontline staff, we're hearing about amazing changes people are making, and it's so inspiring. But as you get further up the chain in management, that evidence is important, but they don't have time to talk about every single member of staff and every single client. They are going to look at data, they are going to look at change, and actually we need that. We need the frontline staff to be putting that data in the right places so we can pull that to actually show the work they are doing, particularly where we, you know, there's financial cuts, we're thinking about posts, and we're having to argue sometimes for, you know, our roles. It's really important to have that to back up, to actually say, this is the evidence. It's not just what I know from X person. This is what I know we're making a difference, and that can be feedback as well. That's a really important piece of data that we use. So I think it's also, when you have that outcome data, it's really important to be able to look at the trends. What is going on? As I said, we use Moho, so one of the domains is skilled. Are we seeing people's skills improve as much as we're seeing their volition? What can we learn from that? Are we seeing different improvement in different places? Do we need to then use that information to think about our workforce? Are we best placed? Are we best placed in hospitals? Are we best placed out of hospitals? We can't just make those assumptions without looking at the data of the outcomes. So that's why it's so important that it isn't data, and putting, doing outcome measures pre and post isn't an add-on. It isn't just, oh yeah, I have to put that data in, the improvement into my electronic patient record system. It is part of the process, because otherwise, all our kind of work and the difference we're making for people just will go unheard, and be incredibly sad that we can't continue.
Thank you so much, Jo. Again, lots of additional points there to the why, and it's certainly something I come across when you talk about, great services that discontinue. That's something that I come across quite a lot in my job. And I guess it's about not taking things for granted, especially in sort of a resource constrained environment that we all find ourselves working in across health and social care. And outcome data is part of that, alongside something that Alex has talked about quite a bit, I think, in his introduction, around using it to create a narrative as well, sort of part of it. So just a little reminder, I haven't actually had a look at the Q&A. One of my colleagues is looking at it, but if you've got questions for the panel about question 1, about the why, now's a good time to start popping those in the chat, because we are heading over to our second question, but we are making sure that we're going to leave about 20 minutes to pick up your live Q&A. So the second question is the how. So the second question is, how do you decide what to capture? And I've been at the professional body since 2019, and in that time, I would say that is the most common question that we get asked as a professional body. I've seen it in emails, I've seen it at conferences, and we now have our new communities platform. And I reckon I could dip into every single network on that platform and see somebody asking, what outcome measures are you using in perinatal or community? So I guess over to Alex for, how do you decide what to capture, and how do you bring people along with you?
Okay. First plug, I've worked with Laura Ingham. She's amazing. Part of her PhD stakeholder group, so definitely read the articles. They're really, really good. The how and the what, I think, are still less important than the why. And I think there's so many different outcome measures out there. You just got to stop looking for the perfect one. There isn't a perfect outcome measures. You've got to find what's best fit, really, and accepting that that's okay. I think the value is so often defined by what the patient wants from the service. Yes, we still got the other stakeholders that we need to provide different types of outcomes and data for. But if we're thinking specifically about the OT element here, then one example of one that I've used in services is OzToms. That was primarily in primary care, frail elderly population. And again, when choosing that, I think I looked at it very much from a perspective of, what do I want from this outcome measure that maybe will help me contextualize the information a bit more broadly. So whilst working with that population that maybe had quite a high acuity, a range of comorbidities, an awful lot going on, I don't think I was aiming ever really to see significant changes within their goals or their impairment or that kind of participation restriction, those sorts of elements to that activity limitation. I don't think I particularly ever expected to see that, because actually in the broader context of that, using that outcome measure with that patient cohort, maintenance was the most important outcome that we could probably achieve for them. Rather than any significant functional change, it was helping those people maintain and manage at home for as long as possible. But what that measure in itself gave were those other elements. So you might see a change around some of the limitations aspect, but it was the client and carer distress scores that were particularly key for me in terms of looking at that, because so often the person that we're there seeing is less impacted by the person than the person that's actually doing the caring role at home, particularly if we're seeing someone maybe in cognitive decline or with memory problems. Then actually we need to help that individual as well, because they're probably the bedrock that's keeping that person at home primarily. So I think again, I always use the term multifaceted in terms of the way that I would use outcome measures, is because you have to use them within the context of what you've got, but you will always be able to apply them more broadly. So data is our friend. Data is something that we can utilize to show the message that we want to show. But it isn't all about standardized measures. It's letting the data do the work for you as well. It's keeping it live, keeping it agile, and remembering that it is a tool that helps us demonstrate value and results. But like I said, standardized measures won't be enough alone. So for me, the services that I set up in primary care, the baseline of our data was probably what a lot of services capture around that activity. But if I had a service that was seeing 200 patients a month, just as an example, then you then got to ask yourself the question of, so what, don't you, within that conversation? It's numbers, isn't it? What does that actually mean? So this is, again, where you've got to provide the narrative and the background to what that means, and paint the picture for those that aren't going to know. Whether it's a standardized measure or a non-standardized measure, the range of stakeholders that you share it with probably won't understand them anyway. So the narrative that you're providing behind it is probably what's most important anyway. So if I had 200 people coming through my service that month, I want to start demonstrating the value of OT. And the value of OT is in the interventions that have been provided to that individual. So if I've got a data capture, and to be honest, there was a simple drop-down list on an Excel sheet, which enabled my teams then to capture, I think I only had 3 columns as an example within it. SharePoint list is probably much more user-friendly to capture even more than Excel does. But what that allowed me to do is then say I had 200 patients referred, 170 patients were appropriate, but we provided 600 odd interventions. Then suddenly you're saying, well, okay, now we're starting to paint this picture of the value that OT is adding, because each person is getting on average 3 point something interventions. So we're really showing that holistic nature, that ability to really wrap around the individual and do as much as we can possibly do within that community space to keep that person at home and as well as possible. And then I guess my last quick 2 points on that question really is, it's a bit of a cheesy line, but it's a quote that stayed with me, that leadership is about making other people better as a result of your presence, and making sure that impact lasts in your absence. So for me, it's what I said in my introduction. For me, I'm not the person that has the most knowledge around outcomes, but I'm the one that's not afraid to give it a try. I'm not afraid to make changes and go, actually, this isn't working. Let's try something different, and get the perspectives of a wider range of people to be able to do so. And sharing that with your team so that you're not solely responsible for that, so that they understand the value, they understand where it's going, how it's being used in all of the different forums, whether it's it could, like I said earlier, in patient forums, or whether it's going to bigger stakeholders, or whether it's going into those financial decisions. Then you've got to know how to present that data. It's the same data, but you'll just use it in slightly different ways. Use the expertise that surrounds you, because our health and social care system is full of people with expert skills and knowledge and an ability to look at things differently. We don't have to have all of that knowledge ourselves. So our finance teams, our value-based healthcare teams, our IT colleagues, all of these people are around us within these services to utilize. Link up with them, ask them for ideas, see what you could start doing with them, because they will really help you with that what question that goes way beyond the standardized measure that you might be using, and we'll show you how to get the full value out of it.
Thank you so much, Alex. Keen to try and get to some questions. I can see we've got quite a few, but obviously still got two panelists. So we'll try to maybe just stick to maybe just a couple of minutes each, if that's okay. Sorry to shortchange you, but Catherine.
Yeah, I'll be really quick. I just wanted to add, everything that Alex said also. So I think trying to be systematic in terms of how you might want to plan things out. So I like thinking in frameworks. So for instance, we know from a health systems lens, there's the quadruple aim. So thinking about, I want a patient reported outcome measure. I want a patient experience measure of some sort. I want to think about value. We might not always be able to get the costing, but to think about like what outcomes we might take to sort of imagine costing. I'm going to also just quickly say feasibility. I think feasibility is everything, because if you choose a battery, and I've seen this time and time again over my career, you have high hopes, but the reality is we're tight on time and money. And so you need to choose one assessment or one outcome measure that you think you can reliably and routinely collect with good data so that you can look at it. It's better to do one versus a whole bunch that you can collect. And I like the idea of, and this is my geeking out on evaluation, but I like the idea of a program theory. So, Alex was saying you do an intervention for a purpose because you think an outcome's going to happen. So thinking about aligning the intervention with the outcome and thinking about what framework you might apply to determine what outcome you want.
Thank you so much, Catherine. And over to Jo for the last response.
Yeah, so from a client level, I think it's what are clients expecting from the service? What are they expecting from our OT service to support them? And obviously having that, and then also thinking from the clinicians, what are they feeling that the OT service would make? What changes would they make? And then thinking about those kind of collaboratively, as well as what is the service around us expecting. So it's kind of taking all those views to think about kind of our assessments in terms of like what we actually capture as an OT assessment, but then also in terms of other outcomes, rather than deciding what to capture, what's already captured. So I know in our trust, we have a data warehouse, and actually I often go in there exploring, going, oh, we're capturing this because we've got a KPI on it. Okay, so we've got re-referral data. Can I correspond that with the clients that the OT is seeing? Can I see if actually by seeing an OT, you're less likely to be re-referred to a community mental health team? So sometimes it's actually some things there, and it is kind of trial and error and looking what's available to you. But in terms of bringing people with you, I think the culture is such a huge thing. Amount of times when I, get introduced to do presentations, like, here's Jo with the data again, yawn. And actually that's not helpful kind of culture. We need to shift that. The data is integral and it's part of it. And actually I added a couple of slides, which I hopefully can be provided to you, but I did a game as part of my training of Convince the Commissioners. And I got OTs to actually pretend they were developing the OT service, and the other half had to think about they were the commissioners and they had to kind of look after their money, and they had to think, well, what do I need to show to demonstrate I want this OT service, or I want to expand this OT service? By gamifying and getting people to think from a different perspective, the feedback I had was phenomenal in terms of I actually felt the penny drop. I actually get it now. You're not just kind of nagging me. All the problems I'm having, if I collect that routinely, a lot of them would be supported in terms of me feeling understood about my role, etc., etc. So I think we need to really think about the frontline staff, because a lot of the time we say, do this, but why? Why are they doing it? What even is data anyway? So I think thinking from that point of view and going back to basics and not assuming any knowledge.
Thank you so much, Jo. I'm just going to sum up what I've heard as some of the key points from that before I hand over to Elizabeth for the live Q&A. And what I've heard is about getting a team round. There is no perfect outcome measure out there. It's about getting together as a team and thinking about what is it that we're actually trying to achieve? What is it we're trying to measure? Don't reinvent the wheel if there's stuff out there already, but also think about the feasibility side of it as well. Think about the feasibility from the person's perspective of filling in an outcome measure, as well as the staff. And then, of course, there's the feasibility for an organisation in terms of your electronic record and who actually can do something with that data as well, so that you can then bring it back to your teams and departments to be able to have a conversation around it. So that's all from me. I'm going to hand over to Elizabeth.
Thank you, Susie. It's such a fantastic conversation. Well done, everybody, for engaging in the chat and for asking questions. I'm just trying to think about an organised way to bring some of these questions together. And I'm going to start with a question that I think, Catherine, you might be the person to start off with that, but if other people chip in as well. And it's how to demonstrate the positive impact of early intervention and prevention in terms of resource and finance across the whole health and care system. It's not an easy one, but it's really relevant. We're focusing much more on those areas now, and it is inevitably difficult to capture that sort of impact. So do you have any thoughts or wisdom from your experience?
Because oftentimes early prevention is about what doesn't happen. And so, you know, how do you capture the falls that don't happen? How do you capture the disease that doesn't transpire? And so I'm going to say large data sets. And so, you know, by looking at population level data, I think that's partly what we can look at as well. And so, again, it can be hard to track the non-falls, but if you look back at when an intervention happened and look sort of at and bring the data together at a whole, and I'm not sure how much, and I apologize for not being as familiar with your data and health use sets, but I would be looking at some of the pre-collected data. It's very hard otherwise to slowly gather that evidence.
And I suppose that links with something I was wondering when you were introducing yourself and talking about performance measures across systems and in populations. Do you think that that's everybody's business, or do you think as OTs, you know, where do you start with thinking about that, or do you wait until you're in a certain sort of role where that's part of your remit?
No, I've been thinking about a lot because I think what happens is as occupational therapists, we get, you know, working in a hospital, working in a community setting, and we start to lose track of large populations and the population thinking. You know, we talk about equity at an individual level, like we want to make sure this person has services, but we actually forget that we touch so few people because we tend to have intensive services. Versus if we think about upstream services and health prevention, promotion, community development, I mean, we can impact swaths of people and be able to provide people with, you know, healthy living and participation in very different ways than we've been thinking about. We think about rehabilitation, but I always say this from a primary care perspective. We provide occupational therapy services. It doesn't have to be after an injury and after a fact. And so thinking about bigger data, population level, community level, I personally think that's where we as a profession needs to be thinking about. That's where the system's talking about. So I think we need to think about outcomes in that way too.
Absolutely, thank you. I'm going to move on to a bundle of questions that are all related again, and that's about this million-dollar question about how do we agree unified outcome measures and at what scale? Do we want them a national set? Do we want them across similar sorts of services? And I wonder whether, Joe, you might lead on this one, because one of the questions was specifically posed to you about how we encourage all OTs to start gathering the same types of data. I'll just add a thought of my own in first, which is it's a question that has bounced around RCOT a lot. And I think we've felt that the sort of thing we're doing today is probably where we want to be providing support so people can have these conversations together, and also going onto the communities platform and having conversations within practice networks and areas of practice so that you can choose the ones that answer those why questions for you. But Joanne, you've done something to scale. So what do you think about joining with others in similar services so that you can start using the same sorts of things?
I think there is power in collaboration. I think, you know, I definitely experienced recently collaborating with OTs in similar fields and kind of learning from and supporting each other. And I think that's really, really powerful because, you know, we shouldn't be working in silos. We're thinking about the wider profession. So I think that's really important. In terms of having kind of, you know, prescribed sets of outcome measures, I'm not sure I would agree. I think there's still an element of kind of postcode lottery between services and boroughs and areas, and actually the services provided are slightly different. So when we're thinking about what are we trying to collect in terms of the outcome, actually, you know, that would be a question: are they the same things if the service being provided isn't quite the same? If a threshold for one service is a particular threshold, and then the threshold is wider, or you're providing a different service, should you be using the same outcome measure? I guess it's a discussion point, but I think I would be kind of not super for it. I would need some convincing and a lot more discussion and thought around that. But I definitely think that, you know, as a trust, so in mental health, we use MOHO. That is a very popular model to be using in mental health. And I've definitely appreciated speaking to other trusts that are using MOHO. But I think the collaboration element doesn't necessarily need to be on the outcome measure you're using, but maybe the processes and kind of how you do that and how you communicate that and what you do with that. I don't think it's necessary that you have to have the same outcome measure unless we are in a position where services are more similar or we are trying to have that comparison across services and be more collaborative. I don't think it's necessary.
I think, I mean, I'm just thinking about work that I've done, particularly in stroke, where it has been really useful to start using the same outcome measures across a pathway. And then that really highlights where there's that discrepancy where people seem to be very, very good when they're discharged from a service and then drop down when they're discharged, they're taken on another service, partly because of the environment, but also because we do have that bias sometimes with reporting fantastic success stories. Catherine, please come in.
Yeah, just going to reiterate, I really do like this notion of some sort of common data set because I think it allows us to compare across within a sector. So you could give an example of stroke or like in primary care, and then we can start to compare across different regions and start to see like what populations, again, thinking at a bigger picture, you know, what regions are struggling for what purposes, like what contextual factors or like social determinants might be at play. So we can start to look at, you know, at tackling other things than maybe than traditional intervention from stroke, but maybe there's like system level social issues that we want to think about. So I am in favor of a common data set of some sort, like around certain populations and settings.
Do you have anything like that in Canada?
In for stroke, most definitely, spinal cord injury, like in certain populations, we do have a core set of data. So again, I think it can be burdensome sometimes, but I think at the same time, it allows for comparisons for us to do better. So we have the Canadian Institute of Health Information that has routine standard collection. So for instance, the FIM has to be collected in intake and discharge for all rehabilitation hospitals.
I mean, I would love to see conversations sparked on in the various networks of our community, the platform, with people saying, actually, who's up for this? Let's see, we're working in the same area. Let's see if we can establish something that we contribute to together. So, and it's really impressive. I've been looking in the chat as well. Some of you have got BI dashboards and things. So I'm also thinking about the kind of inequalities in technology systems available for people to do this stuff. But I think it would be brilliant to start getting people's heads together to think about pathways and systems, and gathering this sort of data. Mindful of the time, but there have been a few questions about what do you do when you've only got a patient for quite a small amount of time, so particularly acute physical hospital settings, or where you're only seeing people for 48 hours. I don't know which of the panelists might have a view on that, but does anybody have any suggestions for those sorts of settings? Or even Susie, or if you've picked up
I
anything
can
from the
talk about
innovation hub.
mental health, acute mental health.
Yeah.
So it is an issue, and I don't think it's something that we personally cracked. I think it's asking lots of questions, as looking at the journey and actually thinking what's realistic and feasible, as Catherine has said, because you know, even actually like writing up an outcome measure takes a lot amount of time. And if someone's like really there for a very short amount of time, also how much impact are you going to be making? So I think that there could be questions there about maybe not seeing outcome measures for an acute. So just an acute service, thinking about cross service. What's the patient's journey across services? Are they going from acute into a community? You know, where are they? Can we think about outcome measures across service line borders? That might not be working for everywhere, but obviously in our trust, we've got different service lines and pathways where a patient would often flow. So we're trying to think about breaking down those barriers, kind of which are self-imposed by care spells on an electronic patient record system or kind of invisible walls of service lines. So sometimes it's taking a step back and thinking, what are you actually thinking you're going to achieve in that amount of time? Can you capture that? Is that feasible? If not, what are we expecting across the journey from acute to maybe another service, if that's feasible for your service?
That's fantastic. And Alex, I wonder if you can answer the next one in the chat, because I probably need to start wrapping up because of time. But there was a question about how to gather caregiver impact. And you mentioned that when you were answering a different question. So whether you'd be able to put some, or if anybody else has any examples they can stick in the chat for people, that would be great. So I think Zoom kicks us out at on the hour, so I will start wrapping up. Kinza, I think there's a slide to share for this if you don't mind sharing it. First of all, I really want to thank all our panelists. It doesn't seem long enough, does it? We could do the whole afternoon. So much to say, but it's certainly got me thinking. And we really do want to have these sessions as kind of, so what next? Thought-provoking sessions for you. So what are you going to do? We've had a sort of a snippet of conversations and ideas today, but is this something that you could repeat in your own settings, in your own team or service or region or even nation? Would it be worth getting some people together to have a similar conversation and think about how you can move things along? Is it that you might want to review the data that you collect and, as we discussed, think about having a unified approach across whatever is relevant in your setting? I've mentioned the communities platform. If you are an RCO team member, then I think it'd be great to get on there, be brave, start a conversation, and see if anybody replies to you. What's the worst that can happen? And please do join our Leading to Demonstrate Impact session on the 17th of November. The link is in the chat, and that will be moving this conversation on to some of the things we've touched on today about, how do we translate this to non-OTs in a way that makes sense and considers the value of investing in our services. And we have recently updated our assessment and outcome measures webpage. We will be putting this recording from this session up on that web page, so have a look on there. That will be continued to develop. I can't get my sentence right now because it's coming towards the end. I've got the pressure of time. We will be continuing to develop that as we go along. So, I've managed to finish before being kicked out, which is a huge win. So thank you again so much, everybody. Thanks for the panelists and thanks for everyone for joining us. Let's continue the conversation. Bye-bye.